are not posted, I think so.
Yeah, good evening. Today we are going to discuss understanding heart-lung interaction, the most important topic in critical care while you are ventilating any patient. Okay. In heart-lung interaction, we always see two aspects. One is the effect of ventilation on circulation. This is the one important actually topic what we are going to discuss. But there is a other part is also there. What is the effect of circulation on ventilation? So daily while managing any ventilated patients, we see both aspects. Okay, one is a lung actually. Okay, and this is the heart. So whenever the lung pressure increases, what will happen to cardiovascular system? That's what effect of ventilation on circulation. On the other way, if heart fails, or you know, example I can tell, beautiful example is this is the heart. Okay, right heart, this is a pulmonary artery. If there is a pulmonary embolism, okay, in the pulmonary artery there is a pulmonary embolism, what happened to the lungs? So there obviously there is no circulation in the lungs. That is called dead space ventilation. Dead space ventilation. So this dead space ventilation every day we see actually in day-to-day practice, but most of us will not concentrate on this. Dead space ventilation will happen because of hypovolemia, because of pulmonary embolism, because of increased intrathoracic pressure. But this is the most, many people will not see this aspect, effect of circulation and ventilation. But we are going to discuss on what is the effect of ventilation and circulation. Okay, this is the one we are going to discuss. Heart-lung interaction is both way actually. What will do ventilation to circulation? What circulation will do to ventilation? So with this understanding, we'll go to the next slide. Here you can see heart-lung interaction can be divided into spontaneous ventilation, how it matters, and mechanic ventilation, how it matters. Spontaneous ventilation, this is a very important point I'm going to talk. Spontaneous increases preload as well as left ventricular afterload. It looks very simple sentence, but to understand this, why spontaneous ventilation increases preload as well as afterload, left and afterload, it needs a lot of explanation. Actually, we'll go one by one. So it is a bit difficult topic, so I'll be slow on this aspect. So coming to the mechanic ventilation decreases preload as well as left and afterload. So it actually works differently. Opposite. Spontaneous ventilation, increases both preload as well as left ventricular afterload. Mechanic ventilation decreases both preload and left ventricular afterload. So maybe you can easily understand this preload, how it reduces. Okay, but with respect to left ventricular afterload, you may surprise that our spontaneous breathing increasing the left ventricular afterload. This is very important. Why it is important? When the patient you want to wean, patient you want to put on TPs, they will have breathing difficulty. Okay, that is now called as weaning induced pulmonary edema. Is a new terminology as I was discussing yesterday last class. So this is because of spontaneous ventilation increases the afterload. So there is the LV failure will be there, that is causing pulmonary edema. Very I'm talking in a different entirely different thing I'm talking now. You will be surprised this what I'm going to discuss today. Mechanical ventilation on other way reduces afterload, left ventricular afterload. This is very important. So these patients who are having breathing difficulty after weaning, put back on full support, they will improve immediately. So how it happens? This is all the, not only in weaning, in many aspects, in many clinical aspects, we can discuss this heart-lung interaction. Basically, I'm giving example to understand, make you understand how it is very important. Okay, so if end of the talk, if you're able to understand, spontaneous ventilation increases preload and left ventricular afterload, and mechanical ventilation decreases preload and left ventricular afterload. If you remember these two sentences, more than enough. Okay, so we'll come to important aspect one by one actually. So okay, changes in lung volume. So it is very easy to understand when the patient breathes spontaneously, or if you put on ventilator, if you take 500 tidal volume, example, if you take 500 tidal volume, or if you breathe and take 500 tidal volume, how it matters to the you know with respect to ventilation. Okay, this changes in lung volume when you increase the lung volume by 500 ml, which increases in both spontaneous and post-pressure ventilation. Very easy actually. Whether you breathe spontaneously or breathe ventilator, if you give tidal volume, it increases the lung volume. What lung volume will do the uh, alveolar vessels and the extra alveolar vessels, that we'll discuss later. Changes in the intrathoracic pressure. This is very important. Okay, so in positive pressure, intrathoracic pressure increases because you are increasing pressure. But in spontaneous pressure, intrathoracic decreases because that's how patient everybody breathes actually. It's a thoracic cavity. If we create a negative pressure in the intrathoracic cavity, then only air enters into the lungs. That is very physiology. What we know, negative intrathoracic pressure will suck the air from the atmosphere. So that is spontaneous ventilation. So this is with respect to lung volume and intrathoracic pressure. Coming to how this lung volume affect the, you know, pulmonary vascular resistance. What is this pulmonary vascular resistance? So if you see this, right ventricle pulmonary artery entering into the lungs. Okay, there is a, even in the lungs there is a vasculature, is the pulmonary arterial vascular arterioles will be there. So this is the pulmonary artery. This is what very important determinant of the right ventricular afterload. This is a very important. Whenever we put the patient on ventilator, we always think about left ventricle, but we neglect right ventricle. But actually, what is more matter, not more matter, equally matters is right ventricle. So when we increase the pulmonary vascular resistance by patient putting on ventilator or with any other way, RV afterload increases, which is directly affected by changes in the lung volume. When the lung volume increases, example, if I increase the lung volume by 500 ml by the spontaneous breathing or mechanical ventilation, that increases the pulmonary vascular resistance, increasing the right ventricular afterload. That you have to understand. The total resistance of the pulmonary circulation depends on two vascular toes. One is alveolar vessels and extra-alveolar vessels. If you are not able to understand in any aspect, you can please you can ask me, so that I will try to answer this. Okay. Okay. We'll come to the next one is, okay. Okay. This is important. This what I'm talking is how the pulmonary vascular resistance matters. This is a very important pulmonary vascular resistance. This is the most important determinant of the right ventricle. Now we are talking about right ventricle. So if you see here, at the higher volume, imagine tidal volume you are increasing or lung capacity you are increasing by by 1000 ml by tidal volume, or minute ventilation increased, instead of 6 liters 12 liters. Okay, what happens? there is a hyperinflation of the alveoli. You can see here the alveoli are hyperinflated. The moment alveoli are hyperinflated, lungs air volume or pressure increases, these vessels, this is called alveolar vessels, will be compressed because they are held between the alveoli, because they are compressed between the alveoli. When the moment these alveoli get compressed, what happens? As I mentioned, pulmonary vascular resistance increases. This is why increasing the lung volume, increasing the total lung capacity, alveolar vessels will be compressed or resistance increases, that again increases the peripheral vascular resistance and can cause RV failure. So right ventricular failure. So what I mean to say is, never try to increase the tidal volume so that it can cause the right ventricular increase right afterload and cause RV failure. This matters a lot. Example, in case of pulmonary embolism, imagine patient is having pulmonary embolism. If you are giving higher tidal volume, increasing the total capacity, definitely already RV failure is there, that worsens RV failure. Okay, not only in pulmonary embolism, in asthma, COPD, I will explain that part. So please try to understand, the moment you increase the more and more lung volume, that causes the increase in pulmonary vascular resistance. What about in other part? Actually, if there is a lungs are collapsed, here you can see lungs are collapsed here, alveoli are collapsed here. It is here lung volume is reduced significantly in the atelectatic stage, that is a residual volume. What happens here? These vessels, the extra-alveolar vessels will be, okay, resistance increases in the extra-alveolar vessels. The moment the alveoli will be collapsed, these vessels will become tortuous. Okay, so that's how blood cannot enter into those vessels. Resistance again increases. So what I mean to say, at higher lung volume, can see alveolar vessel resistance increases because of hyperinflation. At lower lung volume, extra alveolar vessels resistance increases due to, one is hypoxia, because whenever atelectasis is there, PaO2 reduces, that cause hypoxia, that can cause pulmonary vasoconstriction, hypoxic pulmonary vasoconstriction. That word is hypoxic pulmonary vasoconstriction, HPV, and also can increase the resistance in the extra vessels because of the tortuous and tend to collapse. This is very important. Neither we can reduce the lung tidal volume, lower tidal volume, neither nor you can increase the tidal volume. That you have to understand. This is where it matters. It matters in ARDS. ARDS is a important, if the moment the patient put on ventilator in ARDS, actually we are seeing not only lungs, we are looking at the right ventricle. So you should never increase the pulmonary vascular resistance. So in ARDS, we are definitely, we don't want to give more tidal volume. You have to reduce the tidal volume to 6 ml per kg. Sometimes you can go for 5 ml per kg. Then you can for 4 ml per kg. Sometimes 3 ml per kg. See, you cannot. We are increasing the tidal volume gradually so that we can going for protective lung ventilation. But meanwhile, it is also affecting the, increasing pulmonary vascular resistance. Also, make sure that RV failure is not there. How to identify failure, that we'll discuss. So, I think you understood this PVR with respect to lung volume. Same thing explained here also. When the, in PV, in peripheral vascular resistance, here you can see how PEEP works for pulmonary vascular resistance. That is very important. PEEP, imagine you are increasing the PEEP, very high PEEP. Imagine you are giving PEEP of 20 PEEP you are giving, okay? Because if saturation is very low, you are giving high PEEP, 20 PEEP. The moment you give 20 PEEP, what happens? That causes the increase in the intra-alveolar pressure. That increase in the alveolar pressure, as I mentioned here, it compresses the vessels, neighboring vessels, okay? These vessels will be compressed, causes increase in the peripheral vascular resistance. See, you can see here peripheral vascular resistance increasing as you increase the PEEP. As you reduce the PEEP, here PEEP is reduced, so lung is atelectatic, so it can again increase the PV. This is the peripheral resistance due to collapse of the alveolar capillary unit. because of the, and also hypoxic vasoconstriction. So PEEP, what we see PEEP, usually we keep the PEEP of, like a example, we go up to 12, 14, 16, this amount of PEEP is required, even 18, okay. As you increase the PEEP, okay, please make sure that RV, pulmonary vascular resistance is increasing or not. How you identify? Look at the right ventricle, whether the right ventricle failure is happening or not. That's how I will going to discuss that part. So opening alveoli and with appropriate PEEP is helpful to the management of PVR also, peripheral vascular, what is that? Pulmonary vascular resistance also. So what I mean to say now is, so effect of lung volume also causes the problem, and PEEP, both will be the basically related to the pulmonary vascular resistance. So as basically we are talking about right ventricular failure. With this understanding, we are going to next slide. So here you can see it is a slide from my teacher Rami Rajgopalan. So here what I am talking here. So here you can see here how to identify RV failure I am talking here. So when you patient put on ARDS or asthma, COPD, any lung pneumonia patient put on ventilator, look at the RV diameter. That is a very important. Look at the RV diameter. The RV diameter should be always less than LV diameter. Can you see here? RV diameter should be less than LV diameter. It should be less than 0.5, 50%. If RV diameter increasing gradually and it is more than LV diameter, means there is a problem with the RV failure. Very easily we can manage, we can identify. How to put the probe? You should learn putting probe on the patient. So you should know the echo also or ultrasound also to know how to look at these. Very, very easily we can look. We should get a good view on that. We can go for subcostal view, okay, or any view you can get. Easily we can, the supine position, we can get the subcostal view. Look at the RV diameter, LV diameter. That's it. If RV diameter is more than LV diameter, means more than 1, means it is RV failure. In patients who are already hyperinflated lungs like asthma, COPD, okay, and children where there is a pre-existing pulmonary hypertension is there already, minimal changes in the lung volume can cause significant hemodynamic compromise and causes increase in the PVR and cause RV failure. So are we seeing daily these things in our ICU? Yes, you are seeing daily, but you have to open your eyes and see what I'm talking now, it is applying to your patients or not. So we'll see one by one example, we'll understand this. So now come to the effect of changes in the intrathoracic pressure. So now till now we discussed about the volume, but I'm going to talk on now intrathoracic pressure. This is very important. How intrathoracic pressure causes the problem. Okay, heart-lung interaction occurs because this is the one pumping machine, heart is pumping machine. The another machine is there, okay, that is lungs. So there are two machines are there. So we call it as pressure chamber within the pressure chamber. So it means a heart-lung interaction occurs because of heart is encompassed by the lungs in justa cardiac fossa and all are encased within the rigid chest wall. This is what matters here. So both are in the rigid chest wall. So some problem in the lungs, it should affect the lungs, heart. If any problem with the heart, it should affect the lung. That should happen actually because they are together and they are in the same case. Therefore, changes in the intrathoracic pressure affect the pressure gradient. How pressure gradient? This you have to understand. Both systemic venous return to the right ventricle and systemic outflow from the left ventricle. Basically what I am talking is right ventricular input, left ventricular output. We will discuss this. This is very interesting actually. You may feel difficulty in understanding in a few points here, but I will try to give more time if you are not able to understand. So this is very easy in spontaneous breathing. Everybody knows that in spontaneous breathing, intrathoracic pressure, effect of intrathoracic pressure and venous return in spontaneous breathing. So what happens in spontaneous breathing? The moment the moment patient try to breathe in the breathe, there is a negative pressure will be created in the lungs, in fact in the intrathoracic pressure. So what happens here? There is a significant negative pressure is created in the intrathoracic pressure. Can you see this? So this negative pressure also transmitted to the right atrium. That's what I'm showing here. This is the right heart. Right atrium also there is a negative pressure is there. So systemic venous return, how it happens? Pressure gradient between extrathoracic veins, that is the driving pressure, and right atrial pressure. The moment right atrial pressure reduces, okay, because of the negative pressure in the intrathoracic pressure, venous return increases in the right atrium. Increases in the right atrium means preload increases. Okay, during inspiration, right atrium falls further. Okay, because of the negative pressure, and intra pressure increases. Can you see here? This becoming more and more positive. What is that? Intra-abdominal pressure is become positive, and this become negative, which is intrathoracic pressure. Obviously, then pressure moves from higher pressure gradient to lower pressure gradient towards right atrium. One side, abdominal pressure pushing the venous blood to the right atrium, and right atrium is negative because of the negative intrathecal pressure and sucks the blood. So this everybody easily can understand this. Spontaneous inspiration increases this gradient, so accelerate this venous return. This actually acceleration of the venous return that causes right ventricular preload and stroke volume increases. This is very basic, everybody knows this. Coming to the what happens in the with respect to effect of changes in intrathecal pressure, venous and positive pressure ventilation. This is very important. So same works here. Venous return is equal to pressure gradient between extrathoracic and intrathoracic, means right atrium. But here this is positive now, because positive pressure means you are putting positive pressure ventilation. Now pressure is increased in the intrathoracic. So what happens? Right atrium pressure become also more positive. So what happens here? Venous returns is reduces because right atrial pressure is positive now. So you are getting this point. So thus right ventricular preload, hence cardiac output decreases as intrathoracic pressure is more positive. So the moment intrathoracic pressure is more positive, venous return reduces. So where we see clinically these things, we see clinically this point, the moment you put on patient ventilator, moment you put on, or before putting on ventilator, always I will tell, yesterday last class I was telling, the moment you putting on patient ventilator, when you are umbuing itself, when you are umbuing for the ventilation, where you are doing you are ventilating with the umbu, actually you are increasing intrathoracic pressure, you are reducing venous return. If you are not given adequate fluid, if the patient is fluid responsive, or if your patient is vasodilatatory state, or if the patient is having asthma, COPD, already pressure is very high, that patient, moment you intubate, that patient will collapse and arrest, cardiac arrest. So we mean to say that whenever somebody asks you what went wrong, so everything was okay. Yes, everything was okay, because your positive pressure has changed the whole dynamics of intrathoracic pressure with respect to vascular pressure, and reducing venous return, reducing RV output, reducing LV output, causing drop in BP. If you're not noticing, patient go for bradycardia and cardiac arrest. This we have to understand. This is the most important heart-lung interaction we see daily. Everybody feel that moment you intubate, BP drops. BP drops because of your positive pressure. What to do? Just give fluids. Answer is give fluids. Fluids is the answer. Any positive pressure, increasing PEEP. If PEEP causes reducing your BP, means patient is fluid responsive, give fluids. If you put the patient on ventilator, PP dropping, give fluids. That is how it is very easy. But if you have to understand the actual how it works. This is the what I'm talking. Already I've explained this. This is the patient on ventilator. The acute reduction in systemic venous return during initiation of positive pressure ventilation, one of the most commonly observed heart-lung interaction in ICU. Everybody should be. This is called physiological difficult airway. Anesthetist will say that, oh, it is not anatomical difficult airway, It is a physiological difficult airway because airway is not okay. Anatomical airway is okay, but your physiological means your heart rate is dropping, BP is dropping. It's called physiological difficult airway because of this heart-lung interaction. Particularly dramatic in hypovolemic patients, in a patient septic shock, hypovolemia, diarrhea. Okay, if you ventilate this patient, give fluids and ventilate, or who are vacillated because of sepsis. Okay, the fluid flow can partially offset. Sometimes, we can even start noradrenaline before intubation if you anticipate this. How to anticipate this? Look at IVC. You have to, again, I'm telling you should know the echo or ultrasound. Look at the IVC collapse index. If IVC is very much collapsing, means patient needs fluids. Give fluids, then intubate. Try to check 1 second or 2 seconds. We can see this before intubation. Just check IVC. Or if the patient is septic shock is there, means fluid response. No need of IVC. No need of your ultrasound echo. Patient is vomiting, loose motion is there. It is indicate that patient is hypovolemic. No need of any gadgets. Just give fluids and intubate the patient when the patient really needs intubation. That is the important of this point. Another important point I'm going to talk here in COPD and asthma, moment you ventilate, what happens? You can see here, this is a very important slide actually. What is happening here? In the asthma patient, what is happening? Here, this expiration will not be like this actually. Actually, it will be reduced. This is called peak expiratory flow rate will be reduced. Instead of here, it comes here. And it will not touch the baseline. It will not touch the baseline. It goes like this. Means there is expiration is prolonged in case of asthma COPD. Means patient is having bronchospasm. Obviously, expiration is prolonged. So if these patient, what will do? Expiration prolonged. Already there is some amount of air is trapped inside the lung. This is called trapped air or autopeep. So imagine if the patient breathe with this. The first time when he breathe, he will 10 ml of air will be trapped because of bronchospasm, not able to expirate completely. Next breathing, you can again 10 ml is more added. Like that, if you take 100 breath, how much tidal volume will be added here? 1000 ml will be added in the lungs. So this 1000 ml of lungs, example I'm giving, can increase the intraocular pressure significantly. What happens there? Venous return reduces, patient will have a bradycardia and arrest. If you intubate this patient, invariably patient will go for hypotension bradycardia. How to manage this? Autopeep, moment to put the patient on ventilator, check autopeep. Check autopeep. I will tell in another class how to check autopeep and manage this. But remember this, it is a very important here. How to manage this patient is stop ventilating, disconnecting ventilator for few seconds, 3 seconds, 5 seconds, we can save patient. I'm telling in a different way now. Disconnecting ventilator for 3 to 5 seconds when the patient is bradycardia looks, and what I'm talking looks very strange actually, but that is the, that is how the physiology works there. So if you are not in all patients, when there is a asthma COPD, autopeep is there. Okay. And another point here, everybody want to increase the rate in there is a CO2 retention is there, but you have to reduce the rate here to give more time for expiration. Completely different technique works here to save this patient. Instead of increasing rate, you have to reduce the rate. The moment you increase the rate, expiration will be again compromised, autopeep increases. So this is a very interesting point here, heart-lung interaction in case of what you call in case of asthma COPD. Here same thing showing here, autopeep. This is what they are telling, autopeep. Okay, you can identify easily in pressure time scalar. So I'm telling, look at the flow time scalar. Always look at the flow time scalar, tells everything actually about patient care. If you don't know any other scalar, look at flow time scalar. This is the only one scalar tell everything about the patient. Always look at the expiration part. Don't look at the inspiration. Inspiration already fixed because you already selected the constant wave. Always check the expiration waveform, expiration part of the flow time scalar. If you are not able to understand, I can repeat, but you have to interact. If any doubt is there, you can interact. Okay, so we'll go to the next slide here. So okay, this is the dynamic inflation. Oh, here again I'm talking how to, when there is a dynamic inflation, auto PP is there. This is the dynamic inflation because actually here, you know, you should, actually this expression should touch the baseline here before touching the baseline. So another breath is coming here. This amount of air is trapped inside the lungs. So how to manage this? Very easily you can manage. This is the patient is increasing rate. You can see more and more auto PP is there here in case of pressure time scalar. This is, you cannot observe, you cannot see clearly. Here patient is breathing more because patient has become hypoxic or some problem. So this air is trapped here. You can diagnose by looking at the flow time scalar. Flow time scalar, very important. Remember this. So now come to the how to manage this, reduce the rate. Okay, if there is a bradycardia, disconnect ventilator for 3 to 5 seconds. We can discuss in asthma or COPD ventilation. Coming to the next important point here is how the effect of changes in the ITP, intrathoracic pressure, on left ventricle. This is a very important. So far we discussed about the right ventricle. Now we are discussing about the how pressure problems the left ventricle. Okay, so to understand this, you should know what is transmural pressure. Transmural pressure, the terminology is transmural pressure, TTM. It is the pressure between two compartments. That's it. There is no big definition you want. Imagine if there is this one cavity is there. Transmural pressure means what is the pressure difference between this cavity and surrounding pressure. If it is a lung pressure and pleural pressure. That's it. If it is a left ventricle or heart, imagine ventricle is a chamber, left ventricle minus pleural pressure. So surrounding pressure. So intravascular pressure minus surrounding pressure, nothing but transmural pressure. Why it is important? That is the pressure which increases or decreases the afterload. If you are able to understand this, we can easily manage any patient. Okay, very important here. The transmural pressure, of aorta. He is taking example of aorta here. The difference between pressure between the aorta vessel and pleural pressure, because pleura is next to one in intrathoracic. In extrathoracic means in abdomen, it is abdomen pressure. That's it. Abdominal aorta minus abdomen pressure. During spontaneous inspiration, this you have to understand. During spontaneous inspiration, what happens? Pleural pressure becomes negative because everything pressure becoming negative because of the negative intrathoracic pressure in spontaneous breathing, because you have to suck the pressure, air from environment. It creates negative pressure in the pleural and as well as intravascular aortic pressure also. I will explain this. Let's concentrate. This is the important point here. Fall in the pleural pressure is relatively greater than the fall in the aortic pressure. So transmural pressure actually increases, resulting in increase in left ventricular afterload. So what I am talking here is spontaneous breathing, normal spontaneous breathing, increasing the left ventricular afterload. Looking very strange here. So it is like I'm talking different words, like spontaneous breathing is normal breathing. But I am telling here spontaneous breathing increasing the left ventricular afterload. If you are able to understand this, we can manage any patient actually. This I will going to explain. So try to understand this actually here. This is the left ventricle. Okay, this is the left ventricle. Okay, this is left ventricle. Okay, left ventricular pressure is 90. 90 is the pressure. Here patient is spontaneous breathing. So this is the pleura. Pleural pressure is minus 10. So what is this left ventricular pressure is 90. So what is transmural pressure? Aortic pressure minus pleural pressure, because this is a transmural pressure. So what is the transmural pressure now? 90 is the left ventricular pressure minus of minus 10. So it become positive. So it become 100. So what we actually think that spontaneous breathing is good for heart, but I am telling here actually spontaneous breathing increasing the transmural pressure is by 100. Actually it is 90 was good, but it is increasing by 10. 100 pressure is there. So the more and more negative pressure is created. Imagine patient is tachypneic now, is creating more negative pressure. Instead of minus 10 to minus 20, 90 minus of minus 20 becomes 110. So more and more negative pressure is created here. Left ventricle cannot contract because surrounding pressure is completely negative. This negative pressure is not allowing to left ventricle to contract. So whenever the patient on ventilator put on spontaneous breathing trial SBT, that I was explaining yesterday last class SBT, what is happening here? The left ventricle is, you know, struggling to contract because there is more and more negative pressure that is increasing the transmural pressure. So what is happening? Left ventricle are using more and more oxygen. The left ventricular oxygen consumption increases, but delivery is less because patient is on ventilator. Some problem is that delivery is less. There is a mismatch between oxygen delivery. Patient may get EMI, heart attack, or you can go for LV dysfunction if already LV is compromised. This is called weaning-induced pulmonary edema, what I'm talking earlier. So this is one thing. Not only here, there are a lot of factor works here. This is aorta. Can you see here aorta? Here aorta pressure, whatever the left ventricular pressure is transmitted here, aorta pressure is again 90. I'm talking intrathorax 90. Okay, it is 90 here. So again, look at the pleural pressure is, imagine minus 10 is there. 90 or minus of minus 10, again it is 100. So 90 minus of 100, 90 minus of minus 10 is 100. So transmural pressure again is increasing. Means aorta want to contract to send the blood from the aorta to the abdominal aorta. That is not happening because there is more negative pressure is not allowing to contract. So you are getting this point. So both left ventricular aorta is struggling to contract to send the blood, to pump the blood. So not only that, so there are other parameter also works here. So look at the post. This is sorry, previous slide we go. If you are not able to understand, please tell me. I can explain again. What happens in positive pressure? This is the ventilated patient. The moment the patient put on ventilator, the pressure varies, it reverses. Instead of this minus 10, if you kept PEEP of plus 10, become plus 10. So here I told left ventricle pressure is 90. I told here it is a 90 pressure is there in left ventricle. So 90 minus of plus 10. This is a plus 10. This is not minus, the plus 10. 90 minus 10 is how much? 80. So what is happening here? So transmural pressure is reducing. This pressure, this difference pressure is reducing. Means what? The more and more positive pressure is there in pleura, actually it is helping left ventricle to contract more and more, because more and more positive pressure, surrounding pressure, pushing the left ventricle to contract more. Actually it is helping. This is how PEEP reduces after load. So if anybody asks how PEEP reduces after load, that is by creating more and more positive pleural pressure, helping left ventricle to contract. Not only left ventricle, come to aorta also. The more and more positive pressure is there. Imagine aortic pressure is 90, 90 minus of plus 10 become 80. So actually this positive pressure pushing the blood to the thoracic aorta to the abdominal aorta. And also abdominal aorta will be really low pressure, so easily blood will move from the left ventricle to aorta, aorta, thoracic aorta to abdominal aorta. So actually you are reducing afterload. This is how positive pressure decreases the LV transmural pressure. So positive pressure, the moment patient put one weaning patient problem is they put back on ventilator, positive pressure relax, rest the left ventricle, or you can helps the left ventricle to contract, reduces the oxygen demand, increases the oxygen delivery. Whatever the problem is there, it is solves. So always I say the SBT is always, it's a treadmill test for the patient. So remember this is how it works. So it improvement in the life stress and oxygen consumption. If you remember these things, then you can manage this patient very easily. Other parameters also there. I think all are if people are understanding, or any difficulty is there. Any difficulty in these previous slides? Shikil Pal is there.
No, sir. Understood, sir.
Understood. Okay. So if any doubt is there, you can tell me, or even put in the chat box also. So now coming to the, this is the another point here. So not only that, what is happening here, you can look at this. There is a pressure in the, there is a thoracic aorta is there, abdominal aorta is there. Increasing intrathecal pressure, what happens? Pressure gradient between thoracic and abdominal aorta increases actually. So easily left ventricle can contract and send the blood to the peripheries. So actually reduces the left ventricular afterload. This again, it is one more factor here. Additionally, putting patient on positive pressure or intrathoracic aorta causes pressure gradient to develop between this vascular compartment to extrathoracic system. This is very important. Create a more pressure gradient and easily blood is moved to there. So this is another important example actually. The moment you extubate the patient, some patient will have, will have a spasm, laryngospasm. Even in case of, choking, when the patient is eating, something chokes into the throat, in the trachea. How that works actually, there is a significant acute increase in the, the decrease in the intrathoracic pressure. This is very important. Sudden decrease in the intrathoracic pressure. This negative intrathoracic pressure increases the left ventricular afterload. Okay, so they can cause pulmonary edema. This is called negative pressure pulmonary edema. Very commonly seen after extubation. Not very commonly. Sometimes patient will have this negative pressure pulmonary edema because of immediate extubation, and even in choking, laryngospasm happens. These patients. Intrathoracic pressure falls below the intrathoracic great veins. Here, as intrathoracic pressure falls well below the intrathoracic great veins, collapse. Thus, any beneficial effect of RV preload, that is, don't worry. That is RV preload beneficial effect is very transient. Don't worry. Again, it confuses. If I'm going to tell that part also, it confuses. So this is the weaning induced pulmonary edema, already explained in detail actually. Spontaneous inspiration associated decrease in the intrathoracic pressure, decrease. What is this? Okay, spontaneous inspiration associated decrease in the intrathoracic pressure induced increase in left ventricular afterload, and increase in micro oxygen consumption is one of the major mechanisms. This is weaning from mechanical ventilation is a selective LV stress. It's called breathing is exercise. Explained in detail actually. This is called weaning induced pulmonary edema. So in patient with impaired myocardial function, negative swings in the intrathoracic pressure means more and more negative pleural pressure can cause pulmonary edema. How to manage this patient? When you found that weaning into pulmonary edema is there, put back on ventilator, give some diuretics, okay, or you can see while weaning, prior to weaning, get NT-proBNP. While weaning, check the NT-proBNP. If BNP is increasing, means there is LV stress is there. So you can diagnose it. Once you diagnose, before next weaning, give some diuretics, reduce the fluid, or we can extubate directly to BiPAP, NIV. That is very important. This is the one I am talking when there is a when the patient is want to extubate in case of pulmonary edema. When there is acute cardiogenic pulmonary edema is there, always extubation to NIV BiPAP with some amount of PEEP, like like BiPAP means IPAP and EPAP, some amount of EPAP nothing but PEEP here. This EPAP should be like a 10 or 8 to 10 EPAP should keep and extubate. Even in COPD also it works very well actually. So extubation to BiPAP. So this is why guidelines have come is weaning to prevent weaning and pulmonary edema. We are extubating directly to BiPAP. That is very important. BiPAP means NIV 12, 14A, 12A, something like that. This is another point here. So always we see that right ventricle, this is the right ventricle, this is the left ventricle. So if you see look at the series, you think that right ventricle working differently, left ventricle working differently. But actually they are working together. So this is called ventricular interdependence. How it called ventricular dependence? Again, this is a slide from my teacher, Rami Rajagopalan. So why I am telling here is, imagine the right ventricular preload increases with the more negative pressure or because of pulmonary embolism or increase intrathoracic pressure because of the your high P, high tidal volume. The moment right ventricular pressure increases here, what is happening here? There is a intraventricular dependence. Actually, if this septum will be pushes towards left ventricle. The moment intraventricular septum is pushes towards left ventricle, okay, left ventricular space will be compromised. Actually, output will be reduces. This is how right ventricular failure, right ventricular dilatation, in because of the interdependence of the interventricular septum, it compromises the space of left ventricle, reduces the preload because it cannot take any preload. So left ventricular afterload will be reduces. Till now, what you understood? If right ventricular preload decreases, you know that in series it go to the lungs. Actually, in between lungs will come here. Lungs will come, go to lungs. And actually after lungs, left ventricular preload will be reduces and left ventricular output will be reduced later. So in series, RV preload reduces, it reduces the LV preload. That is in series. But in parallel also, if RV failure is there, more and more volume is there in the right ventricle because of intrathoracic pressure, increased intrathoracic pressure, it compromises the left ventricular function also. This is called left ventricular interdependence. This is very nicely seen in case of pulmonary embolism. Again, this slide is the pulmonary embolism case actually. Here you can see RA, RV pressure, you can RV diameter is less than LV diameter by 0.5. Here increasing because of pulmonary embolism. It is right ventricle is completely pushing toward left ventricle, and you can see here left ventricular space is compromised here. So this is called D-shaped LV. Classical seen in pulmonary embolism, D-shaped LV. Classically seen in case of pulmonary embolism, D-shaped LV. So how to diagnose LV failure here in this case? RV dilatation will be there, okay, and RV diameter will be more than LV diameter by 1, means 1.0. Flattening of the interventricular septum, flattening or pushing interventricular septum towards left ventricle. No phasic collapse of the IVC. IVC, you can see IVC completely dilated here, and there is a tricuspid regurgitation will be there. If you look at the regurgitation here, because of the RE and RA dilated, more and more regurgitation will be there towards right atrium. So this is how we can diagnose right ventricular failure. This is the importance of the this will be seen in pulmonary embolism. Here you cannot manage the patient intubation. Yes, intubation is important here, but intubation is not the answer here. If pulmonary embolism is there, you have to remove the clot by thrombolysis or by doing surgery. So thrombolysis is the answer in ICU, thrombolysis. So every time many students think that patient is having breathing difficulty, intubation ventilation is the answer. No. Intubation ventilation is the answer, okay, to improve oxygenation, to improve ventilation, to reduce work of breathing. But why there is a breathing, why there is a pathology is there? If pathology is pulmonary embolism, treating pulmonary embolism is the priority rather than managing ventilator. So you have to treat the pulmonary embolism. Say like that, if pancreatitis is the problem, treat the pancreatitis also. It is not the only ventilation. Treating pathology matters to get a better outcome. So this is I think in next 10 minutes I'm going to discuss this phasic changes in the stroke volume, preload responsiveness. So remember this very important here. This is the tidal volume, okay. If you understand, this is the patient is on ventilator, no, positive pressure. This is the positive pressure. Imagine you are giving tidal volume of 500 ml. Example I'm giving. So the moment you give 500 tidal volume, so what we expect here is, as we explained so far, is right ventricular preload should reduce because you are increasing intrathoracic pressure. That indirectly reduces the right ventricular output, indirectly reduces the left ventricular input actually, and left ventricular output should reduce in series. But if you put a artery in here, somebody has put artery in, imagine, see here. In breathing, in spontaneous breathing, you can see here arterial pressures are increasing, and in this expiration, this is the patient is expiration. Expiration, arterial pressure is reduced. Again, during inspiration, arterial pressure is increasing. Why it is so? Actually, it should be reversed, because the moment you ventilate and put on ventilator, this volume should reduce the preload, actually should reduce the left output, and BP should, this is a systolic BP should reduce, this is artery line. But that is not happening here. Actually, it is happening, is seen in the expiration. Okay, why it is so? Anybody try to answer this? Why it is happening? Another 5 minutes is there. Anybody want to answer this? Okay, this you have to understand. This is very important. Mechanical insufflation may decrease the right ventricular filling and consequently right ventricular output. But this effect of reduction in the right ventricular output will be seen during the expiration, because there is heart is there in between. That is called blood should move towards, lung is there in between. Blood should move towards the lung. There is something called pulmonary transit time. It will take few seconds. So this reduction in the right ventricle, that blood will go to the lungs, from lungs through the vasculature coming to the left ventricle. During that pulmonary transit time, the patient will be in the expiration phase. So the effect of reduction in the right ventricle output will be seen in the expiration. This is why in inspiration you will see higher side systolic pressure or mid artery pressure, and in expiration you see lower artery pressure in mechanical breathing patients. So this you have to understand. This creates a variation. This creates a, if you put artery line, if the patient is volume responsive, you can see artery line like this. Phasic variation, you can see this phasic variation. So this phasic variation is called, okay, if the patient is upward artery line, there is a phasic variation is there, means you have to give more and more fluids. So this is called, this again a same explanation actually, same explanation. In positive pressure, if you put here, what is happening? Artery pressure is increasing, during expiration artery pressure is decreasing. This is creating a classical phasic variation. Okay, this is called preload responsiveness. Again pressure increases and reduces in during expiration. Preload response because of the transit time, delayed 3 to 5 beats or 3 to 5 seconds. So if there is a phasic variation is there, means you have to give fluids. If this phasic variation is more than 13%, means 99%, 99.99% you have to give fluids if the patient is ventilated. If the patient is ventilated and sedated and relaxed or well sedated. So it is the one way of telling that, okay, when to give fluids. This is how heart-lung interaction works here. So positive pressure you can see here, artery pressure increasing here, in expiration artery pressure decreasing. This phasic pressure, variation is more than 30%, means patient is fluid responsive. Unless patient should not have spontaneous breathing, patient should be mechanic ventilated, should get a adequate tidal volume, not like a low tidal volume like you see in ARDS, and patient should not be in arrhythmia. If these conditions are met and there is no RV failure, if these 4 conditions are met, then we can give fluids. 100% you can give fluids. This is that guarantee. So in critical care, if you are able to understand when to give fluids, means you can master critical care. So that is the crux of this phasic variation with respiration and cardio. This you can see here. Here phasic variation is not there, is less 90%, less than 13%, means you are actually dealing with the plateau phase of the what is this curve? Starks, I forget his name. Okay, this is the plateau phase you are working. If it is a more than 13%, means you are working at the inspiratory, I mean this phase, increasing phase. I can explain this part later actually. This is called pulse pressure variation. Pulse pressure variation. If pulse pressure is more than 30%, you can give fluids. So there are so many theories are there. We can discriminate, I'm sorry here, which will discriminate the responders and non-respond with respect to fluid responsiveness. 94% positive predictive value, 96% positive predictive value. Why there is a this problem is there lesser percent? This because of these things. If there is a spontaneous breathing is there, don't use pulse pressure variation, because the preload Either interaction is different actually, as I mentioned earlier. Arrhythmias is there, beat to beat variation is there. RV failure is there, means pressure is not transmitted. Low tidal volume, you need bigger tidal volume like this. If you, the moment that reduce the tidal volume is there, the phasic variation goes off. So will not be seen. Here we can see phasic variation if the larger tidal volume. But in ERDs we cannot use large tidal volume. These are the limitations are there. But you have to understand this. So ultimate message is, this is the message. Phasic, spontaneous ventilation is, if you remember spontaneous ventilation, the increases preload and return afterload, and mechanic ventilation decreases preload left afterload. Then this class means it is done. So any question on this? I know there will be a lot of confusion will be there. If any question, Dr. Shikil.
Sir, I have questions, but I think that I will ask in the chat box later on.
Okay. Anybody want to discuss? Clear, sir. Sundaram told clear. Okay. Yeah, it looks difficult actually, but if you read it once again, you can read. You can go Google it actually, get down article, heart-lung interaction. Now you can read, you can understand in better way. Because unless somebody teaches you how it works, you cannot understand. It's very difficult to understand. Anybody, any question in this? So many doctors are now today are there. Manasa is there. Nesara, any question you want to discuss? Nilofer? Okay. Salman Hussein? Okay, I can see this many people. Still many people are there, I cannot see.
Sir,
Yeah,
sir,
tell me.
low tidal volume means it will be 6 ml or less than 6 ml per kg tidal volume, is it, sir?
Low tidal volume is 6 ml per kg.
Okay.
So normally is 8 ml per kg, low tidal volume 6 ml per kg. When the moment you put low tidal volume, PPV, as I told, intrathoracic pressure is the main thing, no? As I mentioned. If there is no volume, major volume change is there, you cannot see the phasic variation, as I mentioned. Okay, this is a phasic variation. Always look at the phasic. You can look at the phasic variation in the pulse oximeter. Even not able to put arterial in. The moment you put pulse oximeter, there is a phasic variation will be there. That itself tells the sometimes you need fluid, patient need fluids. Any other question? Sundaram, any questions? Salman, Manasa is there. Today many doctors are there. Okay. Shikil, what was the question now? In chart you have put?
Sir, actually, I was thinking to be put into the group. I want to little bit read out first also, as you says to me, because it's not an easy topic.
So as I mentioned, no, you read heart-lung interaction. I can send one article also after this.
Yes,
I can send the article. Read
and then
that.
I will put in the chat box, or maybe in the next class I will
Yeah.
ask it.
So it will, if you read the book, no, it will confuse us a lot actually. So I made the very simplified way how lung volume and intrathecal pressure works with respect to right ventricle, left ventricle. If you understand this, is enough. Okay. If there is no question, I will try to close it. Yesterday we are not able to discuss, and somebody was discussing about the, some topic actually, I'll answer that also. What is that? Acetazolamide, right? So I will discuss one point I will discuss here. See, acetazolamide, people usually get acetazolamide in ICU. Acetazolamide in ICU because of the ICP, the patient with ICP, people using neurosurgeon will put this acetazolamide. Always look at the ABG. ABG will have normal anangap metabolic acidosis, NAGMA. So the moment you put acetazolamide is there, what happens here? Actually, it is a carbonic anhydrase inhibitor. Actually, what happens here? The more and more bicarbonate loss will happen through the kidneys. Okay, the moment bicarbonate loss is there, you are not adding acid, but there is a loss of bicarbonate. So that is called normal anangap metabolic acidosis, classically seen with acetazolamide. So how to manage this? Stop acetazolamide, it improves. But somebody was talking for the respiratory alkalosis. Respiratory alkalosis, what happens here? Carbon dioxide is more, bicarbonate is also more. It is a compensation. Never ever give acetazolamide to reduce bicarbonate. Okay, already compensated for the respiratory acidosis. If you want to treat carbon dioxide. That is the primary pathology. Treat the carbon dioxide, treat the lung. Don't try to treat the bicarbonate because it is a compensatory mechanism. Okay, so don't use acetazolamide for the treatment of alkalosis. Never. If you want to, where we see in clinically, acetazolamide used in the ICU, basically for the reducing intraocular pressure, intrathoracic pressure, ophthalmologists use it, neurosurgeons use it. So basically it acts on the renal tubules, removes bicarbonate from the, from the blood, and more water will be excreted. Okay, and also patient be dehydrated. So remember this. Okay, with this, I will try to close this. Have read. Okay, what is the book? Book you can read. Book to read is so book is to. I always tell rather than book, read the update. Update. If you want to read the book, is you can take TEOS, Critical Care Manual. Very small book. Small means it is not the guide as such. It is a manual. TEOS Critical Care Manual. That is good actually. Like a Ganong you see in physiology, you see in case of MBBS, or you can read Fink and Fink in detail if you want to learn Fink and Fink. Fink is a beautiful book. You can read this. Okay, and so many updates. Don't read any other text, many textbook. Try to see the updates. Try to see articles. If anybody wants which article, please message me in the group. I'll send that article. Okay. Okay, thank you so much. I think it's taking time. Thank you so much. I think record version will be there for others who is not able to attend. Thank you.
Yeah.
Okay, I'm closing it. Thank you.